And again, welcome everybody to the Robert Wood Johnson Foundation Systems for Action Research Program and our recurring Research in Progress webinar series. For those of you who might be new to Systems for Action or to this recurring event, Systems for Action is a signature research program of the Robert Wood Johnson Foundation. And our focus is in studying new and innovative ways of aligning medical, social, and public health delivery systems with the goal of improving health and addressing health equity for populations across the country. We fund studies all around the country, testing innovative ways of helping medical, social, and public health systems work better together toward our common interests in improving health equity. And what we do in this webinar series, a couple of times a month, we come to you and we feature one of our supported research teams and give that team a chance to let you know what they're up to and to offer a peek into emerging findings and knowledge being produced by Systems for Action studies, testing innovative ways of aligning health and social systems. And so as we normally do, we're going to feature one of those research teams today. We're very fortunate to feature a research team based here in Colorado, which happens to be where our national program office for S4A is based here in Colorado as well. So this is a more locally based research team based here at the University of Colorado in the School of Medicine with collaborators from the School of Public Health. And with research partners in the Nurse Family Partnership program. So with that, I think I'm going to turn it over to the research team members who are with us themselves to introduce themselves and then kick off the webinar. I will say that as we always do, we will have time for questions and answers. We'll be able to entertain questions from our audience members today. And we invite you to submit your questions using the Q&A button, which you should see down at the bottom center of your Zoom screen if you're with us on Zoom today. You can feel free to type your questions in at any time during the webinar. You don't have to wait for the Q&A session. Type your questions in, and we'll get to as many of those as we can during the latter part of today's webinar. So with that, I'm going to turn it over to Dr. Vanessa Williams and to introduce the research team and others who are with us today.
Thanks so much, Glenn. Appreciate the introduction. Good morning or good afternoon, depending on where you are. We are excited to share update on our S4A, or Systems for Action grant. Since this is our third and final year of our grant, we're looking forward to sharing our findings with you all. We're going to go through some quick introductions of our presenters today. I'll start off so you know who I am. I am Vanessa Williams, and I am an assistant professor of pediatrics at the University of Colorado. I am a mixed methods health services researcher, implementation scientist, focused on maternal child health and based at the Prevention Research Center for Family and Child Health. I'm going to pass it to Greg to introduce himself, and then Mandy and David can go next.
Thanks, Vanessa. So hi, everyone. My name is Greg Tung. I'm an associate professor in the Colorado School of Public Health. Like Venice, I'm also and self-identify as a mixed methods health services researcher. And I'll also mention that I've been doing research related to the NFP for close to a decade now. I'm really enthusiastic and proud to be a part of this project and looking forward to sharing our kind of work in progress on preliminary results. So I'll stop there, and then I'm going to popcorn it to Mandy.
Hi, I'm Mandy Allison. I am also an associate professor at the University of Colorado in the Department of Pediatrics. I'm a practicing pediatrician and health services researcher, and am the co-director of the Prevention Research Center for Family and Child Health at the University of Colorado with David Olds, who will introduce himself next.
Hi, I'm David Olds. I got the NFP ball rolling 45 years ago, and I'm currently a professor of pediatrics, and I'm honored to co-direct the Prevention Research Center for Family and Child Health in the department with Dr. Allison.
Thank you so much. Thanks, everyone. So we're excited to have David provide a commentary for us today. We're just going to quickly acknowledge the rest of our project team and collaborators for this particular project. Obviously, it's not just the four of us doing all this work. We have some additional project team members and also our advisory committee representing folks from the National Service Office for Nurse Family Partnership and Child First, and then also representing Illuminate Colorado, which is a local nonprofit here in Colorado. So I'll just give a quick overview for those of you who aren't familiar with our project. But the purpose of our project is really to look at how different sectors might influence in terms of their financing and delivery of NFP, and how that affects the reach of our program and impact of the program on specific maternal child health outcomes. And we're focusing on the Nurse Family Partnership or NFP program here in the United States. And this particular project uses a mixed methods approach. So Mandy is going to give some overview of a little bit more about NFP, and I'll pass it on to her.
I always feel like this is a test when I'm doing it and David's on. So hopefully I'll do okay. So Nurse Family Partnership was started by David Old in the 1970s. And it is a nurse home visiting program that begins during a birthing person's pregnancy and continues through the child's age 2 years. It's focused on first-time parents and people who are facing adversities and have risk factors for poor maternal and child health outcomes. After 3 randomized clinical trials in Elmira, New York, Memphis, Tennessee, and Denver, Colorado, the Nurse Family Partnership, based on extensive evidence of its effectiveness, was disseminated throughout the country. And next slide, Venice. That's been happening and since about 1996. And now there are 376,400 NFP families who have been served, and NFP is located in 40 states. And the National Service Office for Nurse Family Partnership and Child First is the nonprofit organization that's charged with identifying new locations for NFP and supporting new sites in developing NFP, as well as providing ongoing sites to existing NFP locations and ensuring fidelity to the model that David developed, but that continues to evolve. I'm done with my part, Venice.
My part. And maybe I'll riff off of a little bit of what Mandy has talked about, and just note again that the NFP really sits on decades of evidence. The program just wasn't developed yesterday or last year. It's been around for quite some time. But I think there's also a culture in the program, even though there is a really strong evidence base, to continue to be rigorous in terms of thinking about how to maintain the effectiveness of the program and what needs to happen in order to continue to push and use the best available research and evidence to maximize its effectiveness and make sure it reaches the right populations as well. And I think a part of that is also a re-recognition, re-examination, a re-embracing of, even though the program has a really strong evidence base, a real recognition that the effectiveness of the program is also strongly impacted by the broader system and the partners that the program actually ends up collaborating or working with. And moving forward, as system dynamics continue to evolve and change, and our knowledge continues to evolve and change, what needs to happen in order to position the program in the best way possible to maximize its effectiveness within that broader system, and also think about what lessons can be pushed out about systems dynamics and collaboration in general. So I'd say all of that kind of motivation has been funneled into these three aims, which are the aims of our project. Aim 1, to assess the degree of collaboration by site between NFP and cross-sector providers, including healthcare systems and social services. Aim 2, take that assessment or those measures of collaboration and pair them with program outcomes to estimate the relationship between site-level collaboration and program outcomes. And then aim 3, which is the more qualitative kind of mixed methods component and practice integrated component, to identify and disseminate the best practices of successful collaboration with health systems and social services, both to improve the NFP and to disseminate more broadly to make kind of broader systems functioning better. Next slide, please. Okay, and so here's our conceptual model / theory of change that kind of grounds all of this work. And maybe I'll try to put it within that kind of framework that I just put forward about the NFP program and how this particular project really embraces as a re-examination of how the NFP program sits within the broader system. I think the backbone of the program here is this kind of yellow flow running through the center of the slide. And I would say maybe the core program really kind of starts with meeting clients' needs and client retention in the program and how that leads to improved client self-efficacy and improved outcomes for those families. And then our focus here is really, and our project is really looking at those system dynamics and how does organizational collaboration and hopefully better organizational collaboration lead into increased care coordination, which has a big impact on the program's ability to meet client needs and ultimately produce positive impacts and outcomes. And maybe a deeper dive into organizational collaboration and actually looking at elements of systems alignment as well as interpersonal factors and examining how all of those contribute to organizational collaboration. What does that look like? What are all the nuances there? And what are the implications for the program and for the clients that the program ends up serving? Okay, next slide. Okay, and I think I'm passing the baton back to Venice. Venice, you're up.
Thank you, Greg. Thanks, Mandy. So I'll just dive deeper into each of the aims that Greg kind of started to talk about and give you all an update on where we're at and what we've learned since the last year, which is when we presented last. So this first aim, looking at the degree to which collaboration might change over time between NFP and providers in healthcare and social services. We use a longitudinal survey methodology. And we use two specific measures to look at what collaboration looks like, and I'll talk more about what they are. But the measures are relational coordination, and then the second measure is what we're calling structural integration or shared resources. And so I'm going to show a little figure here, just thinking about or sharing how we think about collaboration in the home visiting setting. And so at the center of this figure you see here are the families that we support and serve in the program. And these are families typically who experience adversities, socioeconomic adversity, physical health adversities, other social needs, etc. The circle above that are the different organizations or providers or agencies and services that might interact with the families. And so you can see, on the top right side, there's the Nurse Family Partnership Nurse Home Visitor, and the importance of that relationship, that professional therapeutic relationship between our families and our nurses, that really contributes to implementation of the program. But then also the range of providers that you see listed here that range from healthcare, including prenatal and postpartum providers, pediatrics, et cetera. Also social services like child welfare, housing, early intervention, other home visiting services. And so for us, when we're thinking about collaboration in this setting, we think about relational factors between these different providers, between these different types of organizations and services. And that is a combination of communications. Communication needs to be high quality, but it's also coupled with relationships between the different providers. At the same time, we also think about kind of broader level or spheres of influence. And so we also have the next circle, our organizational factors that might contribute to collaboration. We measure this through shared policies. So these can be things like written agreements, MOUs, that sort of thing. as well as shared funding. So thinking about financial incentives or financial alignment between these different organizations. And then beyond that, at the outer circle are structural factors that may or may not facilitate coordination and collaboration. And so here we measure shared space. And so typically we think about space as in physical space. So this could be sharing of a building, a campus, or simply our nurses having badge access to one of these other areas or organizations. And then finally, shared data. So thinking about shared information systems. And most typically here, we're talking about access to electronic health records or electronic medical records. And so our two measures, relational coordination and structural integration, measure these different factors. And so relational coordination measures these relational factors. It's a 7-item validated instrument. And structural integration measures the structural and organizational elements, and that is a 4-item instrument. So just to kind of ground you a little bit in how we think about collaboration and measure them. And so we conducted a survey with our nurse supervisors in the program for this particular aim, and we're just going to call it the collaboration survey to keep it simple. And so we surveyed all active nursing supervisors from implementing sites of NFP across the nation. In 2018, 2020, and 2021, and you see kind of the different response rates shown here in the different years. And we had a really incredible response rate of 85% in our COVID year in 2020. And you can see things have kind of gone down a little bit since then, but still really great representation of our local programs across the nation. And here's a table just to show some characteristics of the participants in the survey over the 3 different time points. Obviously, the intention was to survey nurse supervisors, but there were times when maybe the nurse supervisor wasn't available or the supervisor there isn't a current supervisor in place. So we had a nurse home visitor or administrator of that particular site complete the survey on their behalf. And then we, sometimes some of our sites are really large, particularly in our urban areas. And so there could be multiple teams within a site. And so that second section you see here, just the number of teams that are represented each year, number of sites represented, and then number of states that are represented. So you can kind of just see kind of the distribution there. And then finally, agency type is a type of entity or organization that implements the NFP program. And the majority of our participants are from local public health departments or public health agencies, more than half of them across all 3 time points. About 20% come from health systems or health clinics that are delivering the NFP program. And then a little bit more, just about a quarter, are from community-based organizations. And then we do have an other category that's less than 5%. And this is typically institutions that are like universities, like educational institutions. So just want to give you a sense of kind of where these participants are coming from and kind of the representation. And so what did we find over the 3 years? Across all the providers, looking at the relational coordination measure, we found just kind of moderate coordination. So kind of just like, they have some communication, but not all the time. So that's across all the different providers that we asked about. In terms of the highest coordination, we saw it with WIC and women's care providers. And then the lowest was with substance use treatment providers and housing. It may not be super surprising that the highest coordination is with WIC and women's care, since that's really the bulk of the time that we've spent thinking about the program. But that a lot of the sites are from local public health agencies, which typically have WIC embedded within them, which also then leads to our second measure of shared resources or structural integration. When thinking about across all the provider types, we saw pretty little shared resources, pretty low numbers in terms of sharing of space, sharing of policies, of data, and of funding alignment. But there were some variations depending on the provider. And so we saw the greatest integration with other home visiting services and with WIC. And so my comment about, most of our agencies being public health agencies, And that integration or shared physical space with WIC isn't surprising. And that many of these local sites also implement other home visiting services. So that's, it's good to get that validation. And then in terms of the least integratedness is really with substance use, again, substance use treatment providers and housing. So we're really seeing an opportunity for both more integration and more coordination with those two particular provider types. Next, we wanted to kind of share some high-level learnings in terms of how these collaboration measures changed over time. And so we saw improved coordination with women's care, decreased coordination with parenting programs, and less integration with parenting programs. And so we'll talk a little bit more about why we think we saw these differences, and I'll show you some graphical representations if that's how your brain works, just to kind of see this visually a little bit. So this slide here shows the coordination scores. This is the relational coordination. Think about those relational aspects of communications and what relationships look like with different provider types. You see kind of three bars for each provider type for the 3 years. And you'll notice that for other home visiting, there's only 2 bars. We didn't ask about that provider type in 2018. We added it in 2020. And so the F statistic, the little blue square there, is just showing what's statistically significant or nearing significance. And so we'll start with women's care. You can see that increase from 2018 to 2020, kind of still in that moderate kind of relationship. In terms of other home visiting, we saw an increase from 2020 to 2021. That's nearing significance. And then looking at parenting programs, that's where we see that significant decrease from 2018 to 2020. That big drop off there. And we really think that might be because we added this component of other home visiting programs and how participants might have thought about parenting programs when we first asked about them. They might have included other home visiting services in there already. And the way we kind of think about the differences is parenting programs are more of those like shorter term, maybe one time or a month, within a month, like a parenting class of some kind to teach about, things like safe sleep or car seat safety, that kind of thing, versus other home visiting would be typically one of the evidence-based or best practice home visiting programs that are typically funded through the federal maternal infant early childhood home visiting program or a home MICV program. That's kind of how we're thinking about the differences between those two particular services. So next, I'll show a very similar slide, but this looks only at the integration, which is that shared space, shared policy, shared funding, and shared data that I talked about earlier. And here, everything is kind of on that lower end. The bars are pretty small, really showing that there's really not a lot of integration with NFP for any of these providers. But you can see kind of where the statistical significance is really in that for parenting programs, again, that big drop off from 2018 to 2020. And I think what I was talking about earlier in terms of coordination, we added other home visiting in 2020, and that's likely what's driving that difference there. So that's what we learned in terms of thinking about collaboration changes over time. Actually, not a lot of changes, pretty stable. Which leads to our second aim of looking at collaboration, the relationship between collaboration and outcomes in the program. And so here we use mixed models and we adjust for client, nurse, and site level factors. And one of the things we want to dig into deeper is to look at comparisons of these outcomes and collaboration measures between sites that are largely funded by the healthcare sector versus social services. And I'll talk more about that here in a second. But just to ground you a little bit on terms of the data we're using for this particular aim, we're using the data from the collaboration survey that I just talked about. That's what is driving, like our predictors in our modeling is we want to look at the relationship between collaboration and outcomes. We also implemented a survey in 2020 that assessed funding sources for our NFP sites. And so through that, we were able to define what sector is their primary funding source coming from. Is it largely public health, healthcare, or social service? And I'll talk about how we define those in a little bit. In terms of our outcomes, we utilize data from NFP through the program data that is collected as part of ongoing program implementation. In there are other important things that we control for, adjust for, including client characteristics like race, ethnicity, age, and so forth, as well as nurse level characteristics and some agency level factors. We have other site level factors that we're controlling for at the county level, coming from county health rankings and census data. And so the particular time frame we're talking about here are clients who had their first visit from 2015 through 2021, so over 6 years. And we include these clients who have a nurse matched to them. And so we match them to the nurse who conducted the first 4 home visits with that client. And the reason we include those who've had 4 or more visits is we think that's kind of like a good threshold for development of relationships and for us to really see this coordination of care and collaboration to really have an impact. We exclude those who stop participating due to this unaddressable reasons of either moving, miscarrying, losing custody, or if their child passed away. And so that's really kind of the thinking about the data that we're using to inform this particular aim. The outcomes you're probably interested in thinking about, hearing what we're thinking about or what we're using or looking at, kind of falls into 3 main buckets. First is program implementation, which we're really interested in client retention. We know that clients need to be retained in the program to really see benefits of the program. So that's a big one. Then we look at client engagement, nurse retention, and then referrals to services. In terms of maternal behaviors, the outcomes we're looking at are smoking cessation, alcohol use cessation, use of healthcare visits, breastfeeding practices and family planning, educational attainment, employment, gaining housing stability, and then use of services, particularly if they were referred to them by NFP. And then finally, infant health. So things like low birth weight and preterm birth, which are typical outcomes we've looked at in this program from the original randomized trials. But we also look at some additional measures like well-child visits and immunizations, as well as hospitalizations and injuries, kind of as a proxy for child maltreatment. So this is a lot, and we won't be able to cover all of it today. So we'll focus on a couple per bucket that you see highlighted here. So client retention, smoking cessation, breastfeeding, low birth weight, and preterm birth. So this is some kind of overall learnings or what we're seeing from our modeling. We're seeing some mixed associations basically by provider type. So certain providers, better coordination with certain providers might be improving or not improving client retention at different time points. We're seeing some positive associations between coordination with specific providers and breastfeeding at birth. However, we did not see any relationship between better collaboration and some of these kind of infant health outcomes of low birth weight and preterm birth, or with prenatal smoking cessation. So I'll show you a series of slides of quantitative results with these different particular outcomes and kind of walk through them a little bit in depth. So first is client retention. And a reminder, Mandy mentioned this earlier, that participants can be in the program up until their child turns 2 years of age. And so, but we look at retention at birth, at 12 months, and then 18 months. And on the left-hand side, you see the different measures of collaboration. So we have coordination with these different providers, as well as integration with these different providers. And then the numbers you see here are adjusted odds ratios, odds of being retained at different time points. And then the red font with the little asterisks are those that are statistically significant. And so big, like higher number, anything bigger than 1 is greater odds of being retained, less than 1 is lower odds of being retained. And so I'll focus your attention to some of the ones that have more consistent or stable estimates in terms of predicting retention across all 3 time points. And so the big one here is the relational coordination with WIC here, where across, from birth through postpartum, 18 months, we see basically that better coordination with WIC is associated with lower odds of being retained at all 3 time points. And then further down, that structural better integration with child welfare or child protective services is associated with increased odds of being retained. And then integration, this is integration with WIC. This is where we see that opposite relationship, where when you're better coordinating with WIC, you see lower odds, but then the integration side, we see increased odds of retention. So that's something we're trying to dig into deeper and trying to understand why that might be the case. And then finally, lower odds of retention associated with more integration with home visiting and more integration with early intervention. So this is just what we're starting to see with our retention analyses as our outcome. Next is our infant kind of infant birth outcomes. So looking at low birth weight and preterm birth. Here, none of these are statistically significant, but you do see something kind of trending potentially in the right direction, but really tiny effects here because, we're not really, everything's pretty close to 1. Next is prenatal smoking cessation. And here we see a negative relationship, but nothing super strong there, but potentially that better coordination with other home visiting services might be associated with lower odds of prenatal smoking cessation. And then finally, looking at breastfeeding. So we look at breastfeeding in 2 different time points, initiation of breastfeeding at birth, and then if they did initiate breastfeeding at birth, did they continue breastfeeding at 12 months? And here you see some kind of mixed relationships here, but that in general, if we're looking at breastfeeding at birth, we see that better integration with mental health and better integration with WIC is associated with greater odds of initiating breastfeeding at birth. So you also see that the continued breastfeeding outcome here, the sample size is much smaller because that really depends on who's already initiating breastfeeding at the onset. So we see that big drop off there. So these are some of our early results looking at these particular outcomes, and we're hesitant to really make any solid conclusions because some of these are pretty small effects, but we also wanted to kind of share this being a research in progress. We want to share what we're learning. We did also want to highlight a couple other covariates or other factors that we're looking at when controlling for effects on these different outcomes. The big one is looking at the primary funding source, and this, like I mentioned, derives from a survey that we conducted looking at the funding sources of our NFP sites, and based on what they selected as their primary funding source, they may or may not only have one. That's why you see the other variable. They're looking at number of funding sources, but we categorize them into different categories. So public health funded sites are mostly grant or federal programs. And so that's typically the MCV program, like I mentioned earlier, or like here in Colorado, many of our sites are funded through the Tobacco Master Settlement that we have categorized as public health. In terms of healthcare, these are typically sites that are funded by either a health foundation or this health system is actually funding it, or Medicaid fee for service or Medicaid managed care is what we've lumped into this kind of healthcare category. Social services is really typically grants. These can be grants through, local, county, or state, or even federal, like through TANF, for example. Then we created a mixed category for those particular funding sources that we couldn't really easily define. Most of the time, these primary funding sources comes from a foundation, and a foundation that has like different kind of focus or emphasized on healthcare and social services, or public health and social services. So we really couldn't tease it out. So we created this mixed category. And then finally, unknown, which is there were a handful of sites that didn't complete that funding survey, but we didn't want to exclude them from our analysis. So we kind of put them in that category as well. And what you can see here is that with the primary funding source, that with the mixed category, we see a positive relationship between being funded primarily through this mixed category and being able to retain clients at 12 months. But then with our healthcare funded sites, we see a negative relationship with client retention at 12 months. We also looked at funding sources, like I mentioned, seems to be relevant for client retention at birth and breastfeeding in terms of statistical significance. And here it's suggesting that the more number of funding sources, we might be seeing better outcomes, which is interesting if you think about kind of the movement towards blended and braided funding. So that's something that we're seeing here in our data. And then finally, agency type here, where we see better outcomes in terms of retention with our healthcare delivery systems that deliver NFP compared to our local public health agencies or government entities, and as well our educational institutions that do fairly well in retention as well, and affecting potentially breastfeeding, continued breastfeeding at 12 months. So all of this to say is there's a lot of data, there's a lot of analyses that we're running, and what we're learning is collaboration matters, but maybe not for all of the outcomes that we're looking at. And so I think the big one that we like to focus on is client retention, since that's the cleanest kind of outcome to look at. But these positive associations between integration with child welfare and WIC and client retention might be just the fact that they're situated within these entities that have a lot of resources, and being potentially having more resources available might retain our clients better. The negative association with coordination with WIC and client retention is something we're still trying to struggle. We're kind of struggling to understand a little bit. So I'm curious if the audience has any feedback on that. But we think it's potentially that maybe there are, a handful of clients who might be hesitant to be engaged with public benefits like WIC to begin with, and that they see their nurse coordinating really strongly with their WIC, counselor, that might make them drop out of the program. So that's one hypothesis. Other results of negative associations between better integration with other home visiting, early intervention, and client retention. That's something we're starting to hear qualitatively, is that sometimes there's a sense of competition when NFP and other home visiting services are delivered through the same organization. And that may or may not affect being able to retain clients. I don't know if clients might move on to another program, but that's one potential reason. And then the role of agency type in client retention and some of these early outcomes that we're looking at, how certain delivery systems of NFP might be performing in different ways. And we're definitely exploring that in our qualitative work that I'll talk about more here in a second. And that potentially collaboration may be less important for prenatal or birth outcomes. We don't know quite for certain, but that's at least what we're seeing in the quantitative way. And qualitatively, we're kind of hearing slightly different things. So we'll talk about that here in a second. I'm going to skip this because I think we're running short on time, but that our next steps are to dig into these analyses deeper by looking at the type of organization that implements NFP, doing some sub-analyses by client, race, ethnicity, since we're interested in looking at this from an equity lens, and then kind of parceling things out by funding source. So looking at those who are financed by healthcare versus mixed versus public health and so forth. So all of this leads into our third and final aim to look at our best practices in our highly collaborative NFP sites who are doing the best. And we do this through qualitative case studies. And we identified our sites based on their coordination. And so they scored 95th percentile or higher in coordination with or integration with some of these different measures you see listed. And they had to have above national average for being retaining their clients. And so we landed with these 5 sites spread across the nation, representing kind of different geographies, as well as agency types. We have local public health agencies, health systems, as well as the community-based organization. And so you can kind of see the variation we were trying to get through these in-depth qualitative case studies where we interviewed the NFP nursing staff, the community providers with whom they collaborate, as well as the clients that have had, really strong care coordination to address their needs and triangulate all these different perspectives. In Colorado, we were able to do some site visits and observations to kind of refine our case studies a little bit more. And then with the other sites, we were able to kind of garner other additional documents and policies, written policies to kind of inform our writing and of the case studies. And so across all these 5 case studies, what we're starting to learn is the importance of strong leadership, which is kind of unsurprising, right? It's that if you have a strong leader within NFP and in the other organizations who value collaboration, the frontline staff are also more likely to be interested in collaboration. And if leadership, identifies this as a priority, it gives capacity and time for kind of frontline staff to do this work. We see some more successes that way. Which kind of aligns with having champions in those different organizations, but also champions across different sectors, right? Not just public health, but also in healthcare and social services and child welfare or WIC and so forth. And then the importance of mission alignment. So degree to which, NFP and these other providers or services have shared goals of surveying populations that might benefit the most from NFP, and that's typically those who are experiencing the greatest adversities, shared goals of delivering family-centered care, trauma-informed care, that helps as well. And then, and especially in our rural case studies, we've learned the importance of these personal relationships with service providers. In more of the urban areas, it's typically a nurse might have worked in a health system before and then moved to work in NFP. And that now they know the clinicians over at that health system and are able to make those connections. So having those relationships are helpful. And then at the structural level, thinking about integrated data systems, we heard a lot about different shared EMRs or the range of what that integration might look like. It can be anywhere from kind of, the typical just having view-only access, which is helpful, but maybe not super helpful for facilitating actual communications or care coordination, to the full spectrum of integrated EMRs where, a nurse can just, ping and send a message to a provider if she has a concern. Maybe they even get referrals to the NFP through the EMR system, or there's flags and being able to see kind of what, those concerns might be. So those are some of the successes we've heard. And then finally, the role of the community advisory board is something that we've heard as well. And there's variation what that looks like. In terms of having their function and kind of like their utility, really to support implementation of NFP within their community, but also being a place for different sectors and different providers and agencies to gather together to see each other, quarterly, typically, share successes, share experiences, make connections, really helps. And then in some of our more successful sites that have a really strong community advisory board, they bring their clients in at graduation, they engage the CAB to really create these celebrations of success stories. So I'll stop there because that was a lot of information, but we've also learned a lot since our last update. And I'm going to pass it on to David to provide some reflections on kind of this particular project. And David, I don't know, you probably recognize this photo. But yeah,
Thanks.
go ahead.
Thanks so much, Venice. First of all, this is a really exciting piece of work you're conducting here. And I just like to take a moment to reflect on this current study and put it in both historical and current context. Because I think this study really holds the potential to guide community replication going forward. Some of you know that we conducted 3 separate randomized clinical trials of NFP before offering it up for community replication, and engaged community service providers in those trials to embed the program in local contexts. In Elmira, the first location of the first trial, which we began in 1977, we created a community advisory board that was made up of representatives from the local department, 2 local pediatric groups. We invited the director of the local health department, the Chemung County Health Department, where the OB clinic for impoverished people was located. The director of the local department of mental health, Department of Social Services, both participated in this advisory committee. We had representatives from low-income housing, and we invited enlisted the people from the Chemung County Office of Aging to did booties for newborns. And we were in planning this study. The pediatrician said, we like this idea a lot, but we had originally proposed using community health workers and they said, we like this idea, but we won't work with community health workers. You need to have nurses who are going to be knowledgeable about health in order for us to really back this. So it emphasizes how critical it is to have trust among providers and corresponding trust among the families that that those visiting them are going to be able to provide the knowledgeable support for them. We created a similar kind of a community advisory board in our Memphis trial, where the program was integrated into the Memphis Shelby County Health Department, where prenatal and well child care were provided. And in our Denver trial, where we compared the relative effectiveness of nurses and paraprofessionals, we found that in Denver County, the services were much more geographically and organizationally dispersed. The system of healthcare was really quite complex. And so we created a community advisory group, but we were unable to, I think, embed the program in the systems of services operating in Denver County because of the kinds of complexities that I just described. And I think that it's relevant that one of the findings from the Denver trial was that paraprofessionals spent more time linking families with other health and human services. And we kept track of what nurses and paraprofessionals did during their visits with clients. And we found that nurses were spending more time promoting maternal health and caregiving and child development. And I just want to say something about the current study. I mean, you have amazing response rates, Vanessa team, for this kind of work. And the conceptualization is so nuanced and so thorough. And I think in some ways, the qualitative findings that you report from looking at these high performing sites aligns with my understanding and experience from Elmira and other locations that honestly makes a lot of sense to me. At least to me, it makes a lot of sense. And in general, I think that this S4A work creates a really wonderful foundation for generating hypotheses about what it'll take to align systems to better serve pregnant women and children and families. And I think that the insights from the analysis of factors that might contribute to system alignment and integration, such as distinguishing the effects of relational coordination and structural integration, sources of funding, agency type, all are going to be useful, provide useful insights, I think, for increasing our ability to create this kind of better system alignment. And I would love to see the summary measures of NFP linkage with other services and whether they predict retention and health outcomes. In some way, a summary conceptualization is a reflection of community investment, I think, and ownership of the program, like what was created in Elmira and to some degree, Memphis and Denver. And I have a few words of caution, but these words of caution are really, I think they need to be taken with this observation. My youngest son used to tell me that I was the master of the obvious. So keep that in mind as I run through these things. But I guess the one thing is that these are statistical associations and many associations that are being tested. So the possibility, even the likelihood that some of these findings are simply chance findings need to be kept in under, we need to just keep that in mind. I also want to point out that health behaviors and outcomes are going to be confounded with retention over time because families with greater needs are more likely to drop out frequently. And the kind of selection that we're talking about over time is going to be only partially managed with statistical controls. And I think that the retention mark variable, although it's quite simple, is in some ways a reflection of the degree to which the program is valued by families. And nurses are able to overcome this natural apprehension that families are, especially those families with greater needs, are going to have about having someone come into their home to serve them. All of the original NFP trials found that the benefits of the program were most pronounced for those with overlapping needs. And we see this in international randomized trials as well. So I think it's going to be important to understand the degree to which sites retain those with overlapping needs. And to what degree is this retention explained by coordination or integration with other services? Finally, one final thought. You know, the finding that healthcare funding is associated with lower retention at 12 months makes me wonder about the extent to which healthcare funding is made up of Medicaid funding. And as we all know, Medicaid typically funds services on a fee for visit basis or fee for service basis. And for nurses, this is a disincentive for nurses to pound the pavement to engage those who are hard to reach, but actually who benefit the most from the program. So we need to be cognizant. This finding may illuminate a factor that needs to be addressed in the replication efforts going forward. And I'm really happy, Venice, that you are going to be digging into that healthcare funding construct. And overall, I just want to thank you very, very much for this excellent, excellent work. Thanks. And with that,
I think we'll head into the
let's go
question
on.
and answer section. Yeah, thank you, David, so much for joining. It's such a joy to have you come and share your rich knowledge and experience with the Nurse Family Partnership, and also just to comment on the Systems for Action project. And then thank you to the team for providing that update. And this team will be presenting their final research in progress webinar when their project is over at some point in 2023. So we'll definitely let you know about that so that you can come back and hear about their final results. So with that, we have about 8 minutes for our question and answer. We may not get to all of them. So if we don't, we'll make sure to give all of these unanswered questions to the team, and they will reach out to you individually to respond. So I'm going to kind of jump around here. First question I'm going to ask is, can you give ideas and/or suggestions to racial and ethnic disparities that exist or may exist in the Nurse Family Partnership? And is that something that you're looking at in your project?
I can address this, and what I can say is that we've been alerted to this as a potential issue since we began the work in our Memphis trial, where 89% of the participants were African American, and we had both Black and white nurses serve the population there, and we did not. And what I can say is that the white nurses were, from what I can see, as effective as Black nurses in serving this population. And it's just, it was reassuring to me to see that having strong interpersonal skills and ability to empathize and be respectful, even in a community with decades and just years and years of racial discrimination. If you have the right nurse who is respectful and engaging, they may be able to overcome that maybe initial apprehension about having someone of another race or ethnicity come into my home. So for me, it's been very encouraging to see that pattern of results.
If it's okay, I'll just add, though, I don't think that we think we've got the final answer on that one, and it's a really important question to ask. And in some of the ongoing research we're doing, we're still continuing to explore that.
Thanks, Mandy and David. Yeah, I'll just add one final piece, is that's one of the sub-analyses we're hoping to embark on, is just looking at whether or not there are any, outcomes, that disparities in outcomes by race, ethnicity. And so that's hopefully can be reported and shared with you all next year.
Thank you all. Yeah, come back next year and hear if they have some more findings on that. Our next question comes from Colin. And I see that somebody named Chris has responded to it via text, who might be somebody that's on your team. So it sounds like they're closely familiar with your project, but I'll go ahead and ask it out loud so that you can respond. But in the vein of funding alignment, do you think your evidence base supports a business case for providers to implement and thus fund the NFP model and structure a value-based payment contract with payers responsible for low-income pregnancies and child health outcomes?
I hate to say it, but I personally don't know that I understand the question. So maybe others can understand it better.
Maybe I'll take a stab at this. And it sounds like Chris has already tried to make an attempt. I would say this. I think the evidence base that the NFP has really been built off of is really looking at outcomes, health outcomes. And when I hear the word business case, I think about maybe health systems investing and independent, or it should be related to those health outcomes, but are those outcomes going to translate into a strong business case, maybe lower, like high value care? I think in some ways, some of the return on investment and economic analysis that have been done with NFP really points to, yes, there is a strong business case. I think some of the statistics that Venice presented in the beginning suggest, and some of that research suggests a really strong return on investment, like $5 back for every dollar invested. But where is that return actually happening, and who's really incurring it? And I think that is something that we're actively exploring. And I think it's relevant to this research and other projects that we have operating in parallel, saying, okay, specifically for maybe a health system that's investing in the program, what are they seeing in terms of a return that is experienced, or the perspective is defined by that particular health system? Team, how did I do? What do you guys want to add?
You're getting thumbs up all around.
Yeah, that's a huge
I think we're good. Thanks for taking us in.
Yeah.
And I think in lieu of time, we'll move forward with a couple of systems for action announcements, and then all of the questions that we did not have time to respond to today. Again, we'll make sure that the team has those in hand, and we'll respond to you. So if you want a certificate of completion for joining today's Research in Progress webinar, there will be a very brief survey at the end of this webinar, and you can indicate at the very bottom that you want a certificate of completion, and we'll get that to you in a timely manner. And then importantly, we do have a funding opportunity available right now. It closes on October 5th. That is the deadline for proposals to be submitted. We are asking for letters of intent to be submitted by September 6th, which is next Tuesday. And these are not required and non-binding, but they do help give our program office a good idea of the types of projects and topics that are going to be submitted to our funding opportunity this year. And so we can recruit some relevant reviewers with that expertise. And we do have some virtual office hours that we're doing this year. So if you have any questions, if you're considering submitting a proposal, you can join for these office hours and ask us any questions that you might have. And we do have our next one tomorrow from 12 to 1 Mountain Time, I believe. It says Eastern Time there, but I'm pretty sure it's Mountain Time. And then
yeah, it's 2 o'clock Eastern Time.
Thank you, Stina. And if you have any questions, please join us, and you can reach out to our team, and we'll answer any questions you have. And again, thank you to the University of Colorado team for presenting today on your research and giving us this wonderful update. And we look forward to hearing more about your project in the future. So thanks everyone for joining today, and hope you enjoy the rest of your day.